Thank you, Kinan, and thank you very much, Unite, for inviting me to speak in this conference. First of all, apologies that I could not come in person. I was supposed to, but I had a sports injury to my right knee while playing golf. So apologies for that one. And I was asked to speak on this paper that has been published about the impact of GP referrals on overcrowding emergency departments and acute medicine. As you can see that I'm an emergency medicine consultant for the last 25 years, and I've seen ups and downs in emergency medicine. And many, many years ago, when I started my career as a specialist in emergency medicine, it's not moving screen. Kanan?
Yeah.
The screen is not moving.
You can actually click the button there because the control is yours.
I'm doing that one, but
okay, can you click on the impact of can you click on your presentation so that it will activate that window, and then you can click on the button.
Okay,
yeah,
thank
perfect.
you. And so as I started my career in accident and emergency at that time, now we call it emergency department, and I thought that it will be accident and emergencies coming through my door. But I never thought that it means accident and not accident emergency, but anything and everything. And that's what exactly is happening in emergency departments at the moment in UK. So why the people turn up into emergency department? And I usually say that there is only one department which is open 24 hours for anyone to come down. And when I say I need anyone, usually they are patients, but sometimes people who are lonely, the people who are homeless, people who have got some mental health issues and they want to speak to someone, they all turn up because they know that they will not be returned or and they will be listened to. And there is one department which is 24 hours open. When I go to work, I expect that at 8 o'clock in the morning, I usually start my work, and I think that there will be few people waiting in our emergency departments. And so we'll have a good time. We will talk to each other, and we will see patients, treat them, send them home, and finish our shift after 8 to 10 hours. But then when we turn up shift, this is how our waiting area looks like. Sometimes there are more than 100 patients waiting for the doctors to start their shift. And this is, at the moment, the people, I know that few of my colleagues from UK are present in this session, you know, and this is a make and break time for the NHS, because only 3 years back, we did not have a 12 hours trolley breach in our department where I'm working, not a single one for years. But now there are more than 50, 60 people waiting for more than 12 hours. In fact, there was a patient only last week who was there in our department for 5 days because there was no bed available in the hospital. Usually the bed occupancy, the safest figures should be around 85%, but over hospital is 100%, you know. Rather, I will say overflowing, because it is chock-a-block in our emergency departments. People are waiting for 24 to 48 hours for beds in the hospital. So I've developed this interest, and we call it a patient flow. And so it's very important, you know, that we need to, because these elderly people, they are being seen by the doctors and nurses in the corridor. There is no privacy, there is no dignity. Some of them, they use the commode, you know, and some of the doctors are using screen to examine them. And it is really, really bad, and we are letting them down, you know. So we need to sort this out, and we need to work together. So we thought that let's look into those areas, you know, why the emergency departments are clogged up, why there is such a big sort of waiting time, why there are no beds in the hospital. So we have a different stream. So one of the streams that we are looking into, and we basically publish it as well, you know, that what are the people who are already seen by another clinician or another doctor, you know, and then they have to come to the hospital. In this respect, I'm talking about the GPs or primary care colleagues, you know. And there are many reasons, and we will look into that in further presentations. So me and my colleagues in the acute medicine, we looked into the patient who was seen by our primary care colleagues in the community and then sent to the hospital. So we also got help from our junior doctors, and we made a pro forma and went through around 139 patients who turned up to our emergency departments when they were seen and referred by our GPs or our primary care colleagues. So as you can see, out of 139, 43 were referred to directly to medicine. 96 of them were referred to A&E. And out of this A&E number, only directly to the A&E are 30. Other specialties, which are surgeons, ortho, ENT, 37. And there was not stated any specialty in 29 referrals. So there were 2 handwritten, which was eligible. And there were one which was had a minimum notes. The age range was 6 to 91 years old. Now, the gender distribution, 37% were male and 63% were female. And we thought that some of them are coming again and again to our departments, and that was sort of my belief. But 80% of the people who are coming were having a new problems. So that was not that they were coming with the same problem again and again. 20% we knew that they are our regular customers. So this is what is a very important slide for us. And to be honest, it was an eye-opener to myself and my colleagues in acute medicine, that the patient who turned up, they were seen by the GPs, more than 50% of these patients were turned back within 4 hours of their coming to our department. And if you see that within 24 hours, that is almost 2/3 of these patients. So the question arises now that were the patient appropriately attending the emergency departments? Were they, can they be seen somewhere else? When I say somewhere else, we need to have a clear-cut policy for that one. Because remember, in UK, my colleagues who are sitting here will understand that one, that our GPs will have an appointment for 10 minutes. So every 10 minutes, they have got a new patient. So they don't have the time to think about it, where they have to refer, whether they refer to community, whether they have to go for the alcohol services, whether they have to refer to the social services. And sometimes they just pick up the phone and they speak. And most of the time, I will tell you that the secondary care hospitals are busy. The doctor can't reply to them, and they have got the pressure of another patient who is turning up next, So they have to refer. I've got full sympathy with them that they can't sit on these patients. But I will be proposing, that there should be a method that they can get in touch with some other specialties or other hub, rather than referring directly to the hospital. But remember, this 75 or 2/3 of the patients come in the hospital, leave within 24 hours. And 50% of them, they will leave within 4 hours, and some of them without any investigations. Now, the GP letters, which specialty they were referring to, as you can see, the A&E 31%, and surgery, peds, ENT, ortho, there are plenty of people, almost second highest, that there was not stated, and the majority of them is that, dear doctor, and that's it. And then they write out that we are referring this patient with knee pain, or for that matter, whatever the complaints are, but there is no specific mention about which specialty they are referring. So as you can see, the presenting complaints, GI or abdominal pain is the majority of the patient. The second one was chest pain. Musculoskeletal and ortho, small sort of green stick fractures in children, or for that matter, any soft tissue injuries comes into that category. But rest of them are, almost all of them are less than 10% each. Headache is one which is quite sort of important for us, because some of the time these headaches can have got a trivial problem, but some of them, they have got a serious problem as well. Similarly, chest pain, only 6%, but having said that, these 6% are very important, that might be an MI and have to be referred to the PCI, and we all know that every minute means every part of your heart, So we have to be very quick. So when we went into see these letters, we thought that we'll look into that one, that whether our primary care colleagues went through and sought to the whether sorted out any alternatives, and 94% were sent in without mention of any alternative sort. So 94% is a big number, When we talk about the alternative, what could be the alternative, When, from my point of view, there are many things, as we all know, that we have got hospital at home services, we have got senior community nurses who can give antibiotics in case somebody is got a chest infection. Similarly, I've seen 2 presentations in the morning about the wounds, how to manage the wounds. Do these patients need to come, all these patients need to come to the emergency departments? No, they can be sorted in the community by the district nurses. They have got all the facilities to do these sort of addressing. Similarly, people who are homeless, people who have got some mental problems, there can be a mental lesion nurses available in the community. There can be a hub there, and they can present there rather coming to the hospital. Because again, I can tell you, one thing which I always say to my juniors and to my trainees is that hospital is not a safe place, and especially the elderly people, because it's full of hospital-acquired infections, And a elderly person who comes to the hospital, we all know that a lot of research has been done that if they lie down on their bed for another 2-3 days, they lose their muscle mass. There is difficulty in mobility after that one. And most of them, when we discharge them to care home and nursing home, they die within the first year. So we need to have more treatment and more facilities available in the community rather than it is coming to the hospitals. Alternatives suggested, as I said, that outpatient referrals, ENT, hot clinics, VT clinics, if somebody has got a leg swelling or pain or shortness of breath, we all treat these people out of a hospital. But then if somebody comes to the hospital, then it has to go through the whole process. Discussion with specialty, acute physicians, yes, 7 of them, but there were 139 referred, So what happened to the rest of them? So the problem is that acute physicians are busy. They can't just basically listen to the calls from the primary care unless there is a physician who is responsible for listening to these calls. Because if there is a referral from 90 to 100 in a day, it is not possible that all can be seen by or listened to the acute physicians. Radiology referral, sometimes they want an X-ray or for that matter, a CT scan. There should be a direct access from the primary care to send to them rather than sending to the emergency department. The 5 of them, they came through the A&E. GP-led investigation and treatment, that can be done in the community rather than sending them patient. Because I know that some of they send it because there is an abnormal blood result, hemoglobin of 8 or 9, or for that matter, in any sort of they want an investigation done, and they will send it that can you do some bloods? And I don't think so that A&E is a place where we need to do screening or doing the bloods. There should be facilities in the community. Now the GP referrals for medicine, 43 of them, aged 17 to 88. 5 did not live in their own home, and then nursing home 3 patients were with dementia, And again, see that 30% of these patients were discharged within 4 hours of their arrival in A&E by the acute medicine. And similarly, if you say the less than 24 hours, it was almost 70%. So same figures, So this is quite important that because when somebody comes in the hospital, the protocol, the guidelines are all, and then to be honest, from my point of view, the hospital doctors, me being for last 30 years a hospital doctor, we are very much risk averse, And these people will have all sort of investigations, and then it will be the post-take ward round, then the consultant will have their, and then they'll ask for the opinion of the other specialties, and it goes on and on and on. And I think there is a delay of discharging back to the community. So that's the reason that I say that first 4 hours or 24 hours, if we focus on that one and try to create a system in the community in which we can prevent these people coming to the hospital, it will be quite beneficial. And as I say, that I have got 3 circles. One circle, I will say that it's the front of the hospital. When we say front of the hospital, it is the community, the primary care, the social care, and all those sort of facilities available. And then it comes to the A&E, and then becomes the back of the hospital where the patients are admitted. And then the last circle is in the discharge from hospital and going back in the community. So there is an overlap of all these circles, and if one circle fails, it will fail the whole sort of a system, We need to work together to make it sure. And I give one more example, being a scientist in a sense that I studied science, and the first thing we learned in physics was the nucleus and the atom. And in atom, there is a nucleus, and in the atom, there is also electron and protons. And I say that our nucleus is our patients. So our patients should get the best benefit, and they'll only get it when we work together, the community, the A&E or emergency department, back of the hospital, and again, when the patient is discharged back to the community. So these are the complaints for the acute medicine: chest pain, chest infection, abdominal pain. And then you can see 12% for blood results only. The abnormal blood results are coming for the acute medicine to see, and most of them probably discharged within 4 hours. So again, 95% of medical patients were referred by GP. 1 patient was seen by ANP. ANP means advanced nurse practitioner, and 1 patient seen by the ophthalmologist. Apologies for a mistake in patient spelling. Alternative sought 12%, and all tried AAA. AAA is adult ambulatory care. And so Betty, there was no answer. So obviously, there was no physician to answer that one. 88% of referrals were sent in without mention of alternative sort. Again, the last time I think it was 90%. So, discussion of over result of this small study was that 2/3 of patients referred to emergency services at WWL, which is Rattington, Wigan, and Lee Foundation Trust, were inappropriate or not appropriate, I will say, and could have better managed by an alternate option. Already I have mentioned few of them in my presentation, that there can be an alternate option in the community rather than sending these people to the hospital. The results are pointing out that we need to develop a robust system of a referral from primary care to hub. And this is very interesting. I presented in a couple of integrated care systems and in my own trust, in their trust board and the management board. And what I mean by hub is that, these people, especially a majority of our patients who are waiting for beds in our hospitals and in corridors are elderly people for more than 75, 80 years old. And they have got their complex needs. They have got long-term conditions, and it's not easy to manage them. So if there is a hub, the hub should not be only, populated with the doctors or nurses. I think it will be beneficial that if we have got occupational health, if we have got mobility assessment of the physios, and also the community and the social work, and with the doctors. So if the call comes from the primary care to this hub, and they will basically assess that one, that where this patient needs, whether this patient is better to be treated in the community, or whether patient needs to come to the hospital. And I say one more thing. I will go one step forward, and I say that anyone who is coming to the hospital should have a passport, and passport to come to the hospital, and that passport should be issued by a hub, which is being seen by a doctor, a senior doctor, by the physios, and by the occupational health, and by the social care. And if they think that, no, this is something which requires a hospital admission, then that person should come to the hospital, because otherwise we are not going to survive for very long as the National Health Services, because it is, as I said before, it's a make and break time. And link of working as a team between primary and secondary care, collaborative work, and the community services, as I said before. So limitations of my study here is that short time period, as you can see that one, that it was not a very long time period. GP letters collected at reception by our receptionist, and letters excluded as they were in some of the letters were excluded, which were the incomplete. So one person collecting the validating data, one consultant suggesting the alternative. So medicine was seen by my acute medicine consultant, and the A&E was seen by me, and we just sorted out that which were the alternative that could have been sorted before patients coming to the hospital. So no official national guideline for GP letters for comparison and auditing. Unfortunately, we don't have any guidelines, So that is one area that people can intervene and make that the national guideline. So input in this audit only from secondary care. So we didn't involve primary care. I'm more than happy to work with them. As I said, that we need to work as a team to work for our patient, which is our nucleus, our practice. And I like this quotation, that's why I put it here. Insanity is doing the same thing over and over again and expecting different results. Every day after 48 hours, the patient gets a bed, and you think that that problem is sorted. But then when you come back again to work at 8 o'clock, there are still people waiting for more than 24 or 48 hours. We are running in circles, doing the same thing again and again, but we are not thinking out of a box because we are set for protocols and guidelines, So the futures plan, facilitating direct referrals to appropriate specialties. As I said, that every referral should come to the hub, and the hub should issue a passport to come to the hospital. Tackling limitations such as being unable to reach specialties already implemented. When I say I already implemented, I already implemented in our own hospital, and that made a big difference. Potential standardization of referrals via set pro forma. This is also implemented. So all the GPs have gotten now a pro forma, and they need to fill it when they're referring a patient to the hospital. This repeat study when the above have been implemented, which we are going to do at the end of this year. Conclusion, appropriate channeling of referrals to secondary care. That's the nutshell of this whole presentation and this study. Developing a hub which can act as a buffer filter for referrals, presence of community services at the front end of the hospital to triage appropriate patients to management in the community, and common forum of primary and secondary care physicians to exchange ideas and discuss the shortcomings and agree on solutions. That's it. Thank you very much for listening here.